Good evening to all. Yeah, I'm thrilled to welcome you all for today's webinar on Diabetes Mellitus, the clinical roadmap to curb the pandemic. I'm Vijay, manager at Mediversal Academy, and I have a great privilege to welcome the speaker for the day, Dr. Ayush Pandey. Dr. Ayush is a consultant physician, diabetologist, and a pulmonologist based in Bhopal, currently working at CMCH and Manas Sarovar Diligent Care Hospitals. He leads the palliative care unit at CMCH and is trained in palliative medicine from the Institute of Palliative Medicine, India. A passionate digital health educator, he has created around 500 plus medical videos and built a YouTube community over 1.5 lakh followers. Dr. Ayush is pursuing the executive program in healthcare management at IIM Shillong and collaborates globally as faculty with the University of Buckingham, UK, and as a medical consultant with healthcare firms in the US and India. Over to you, Dr. Ayush.
Thank you, Vijay, for the very warm welcome. And it is always a pleasure conducting webinar with Team Mediversal. And one of the topics which is also close to my heart, and of course, which has become the pandemic and is, of course, a matter of concern raised even by the WHO. And when talking in terms about our country like India, where this has become a pandemic. So let's start and discuss today's session on the diabetes mellitus, the clinical road the clinical roadmap to curb the pandemic. So we'll be discussing basically the management part per se of it. We'll be talking about what exactly is insulin, oral anti-diabetic drugs, what are the various medication options which we have with us, and how to start a patient who has been newly diagnosed diabetes and accordingly proceed. So as we all know that diabetes is basically a group of metabolic disorders, and it is characterized by chronic hyperglycemia, and there is disturbance of each and every metabolism. There is carbohydrate, fat and protein metabolism that are being disturbed, hampered, either due to either absolute or a relative deficiency in insulin secretion or action. So because of this, there are a lot of long term complications, damage, dysfunction of the various bodily organs, and it also affects the function of the various bodily organs. Now when we look at the criteria for diagnosis of diabetes, and according to the American Diabetes Association, when do you call it as a patient of diabetes or so? So if a fasting plasma glucose levels greater than 126 milligram per deciliter, symptoms of diabetes mellitus, what are the common symptoms like polydipsia, polyphagia, polyuria, excessive thirst, excessive urination, excessive hunger, along with a random glucose level of greater than 200 milligram per deciliter. And if you do a OGTT, that is oral glucose tolerance test, so you measure a RBS and then you give a glucose load of 75 gram, and after 2 hours you again measure the glucose concentration, and if it is greater than equal to 200 milligram per deciliter, that means the patient is a diabetic patient. Now coming to the classification of diabetes that has been proposed way back till in the year 1997. So type 1, what do you call it as a type 1? So there is absolute deficiency of the insulin. And why it has occurred? It has occurred to the damage or complete destruction of the islet cells of the pancreas. So why there is complete damage? Most of the cases can be either idiopathic, sorry, or they can be immunologically mediated. When we talk or compare in terms of type 2, there is relative insulin deficiency. So beta cell is there, beta cell is functioning, but that is not functioning up to so much of the mark that leads to production or insulin catering phenomena. And because of this, there is impaired cell function, there is relative insulin deficiency, and that leads to there is also increased peripheral insulin resistance. There are also some other types, specifically if a female is pregnant, then there is gestational diabetes, and some other like MODY diabetes, which is onset of diabetes in young. So it is basically an autosomal dominant condition, usually occurring in the age group of less than 25 years, and it is non-insulin dependent initially. And why it occurs MODY? So because of the mutation in genes like maybe HNF1A or HNF4A or CGK. So patients are often misdiagnosed as type 1 and type 2, and you have to understand the basic difference between these two. So type 1, what is the age of onset of the type 1? Usually during childhood or puberty, and type 2 most frequently over the age group of 35, but with the lifestyle and all kinds of factors, now even the young people are also getting or developing type 2 diabetes mellitus. So patient of a type 2 can be obese, but of a type 1 is frequently undernourished. If you look at the prevalence, type 1 is generally 5 to 10%, whereas type 2 holds a major chunk, almost 90 to 95%. Genetic predisposition in type 1 is moderate, whereas in type 2 it is very strong. And in type 1, beta cells are destroyed, and because of the complete destruction, the elimination, there is elimination of the production of the insulin. But in type 2, there is beta cells, it is present, but inability to produce sufficient amount of insulin, thereby also occurring of insulin resistance and other defects which is being there. So other types, if we talk about, so other types is genetic defects of the beta cell function, which I talked about, the MODY, maturity onset of diabetes in the young. Along with this, there can be, and it is because of the genetic defects of the beta cell function, there can be genetic defects in insulin action, lipoatrophic diabetes. So insulin resistance, why? Because of the due to receptor defects. So insulin receptor mutations, lipoatrophic diabetes. So because of this, there is severe insulin resistance and high insulin levels, but there is poor response. Diseases of the exocrine pancreas. What are the examples? You have chronic pancreatitis, you have cystic fibrosis, hemochromatosis, even pancreatic cancer and pancreatic trauma. So what happens because of the diseases of the exocrine pancreas? There is destruction of the beta cells. So clinical clue can be, there can be a history of pancreatic disease. Some other examples, secondary or drugs or chemical induced, can be because of the intake of steroids. Most common, again, thiazide diuretics, diazoxide, beta blockers, or thyroid hormones. So it is very important, if you are evaluating a patient of a diabetes, always check the drug history prior in a new onset of diabetes. Viral damage can also occur to the pancreas, like congenital rubella, CMV, leading to direct leading to direct beta cell destruction. And immune mediated diabetes, autoimmune but not classical type of diabetes, anti-insulin receptor antibodies. So there is severe insulin resistance, fluctuating glucose levels can be there, and genetic syndromes like Downs, Turner's, and Klinefelter's. So genetic predisposition with metabolic dysfunction. So these type of diabetes have identifiable causes, and often they are misdiagnosed as type 2, but it requires a case specific management per se. Now, what is basically this? This is basically the response of the insulin to the glucose infusion. So basically, in a normal individuals, if you see this, there is a biphasic insulin response which is being seen. So what happens in the first phase? In the first phase, there is a rapid spike. There is a rapid spike that occurs within the minutes, and there is release of the stored insulin which occurs, and it is important to control the postprandial glucose levels. What happens in the second phase? So in the second phase, there is a continuous insulin release which is being going on, and it also occurs due to new insulin synthesis. So because of this, this keeps the glucose tightly under control. But what happens in type 2? In type 2, there is loss of the first phase of the insulin response, that is the rapid spike which is being there, and there is a delayed and blunted response. You can see this loss of the first rapid spike, and there is a delayed and a blunted response. So what happens? Post meal, the glucose rises rapidly and chronic hyperglycemia develops. So this is the early type 2 diabetes hallmark. In type 1 diabetes, almost there is no insulin secretion, only because of the complete destruction of the beta cells due to autoimmune, and that's why you get a flat or a very low insulin curve which is being there. So insulin resistance, what are the organ involves in the peripheral tissues, liver, muscle and adipose tissue. So what are the effects it causes on the liver? So there is increased gluconeogenesis that leads to increased blood glucose levels in the muscle. It decreases the glucose uptake in the adipose tissue. There is increase in the lipolysis that worsens the insulin resistance. So what happens because of this? A complete net result is hyperglycemia. The second is the beta cell dysfunction, which also occurs, and there is inadequate insulin secretions. And because of this, there is initially, although compensatory hyperinsulinemia, but as the beta cell failure is being there is decreased insulin production. So ultimately, it lands up to hyperglycemia. Now, this is the pancreatic islets, and what are the cell type? You have the beta cells, and 65 to 70%. And what are the hormones that secretes insulin? What is the function of the insulin? Decreases the blood glucose. Then you have the alpha cells that secrete the glucagon that increases the blood glucose levels, and it comprises almost 25%. Then you have the delta cells that secrete the somatostatin, almost 10%. And then you have the pancreatic polypeptide PP, almost about 2%, that helps in the GI regulation. So beta cells, if you see, these are the almost are the central in the islet, and alpha cells, if you look at this, these are more peripheral, which is being there. So blood flow occurs from beta to alpha to the delta. So in type 1, there is destruction of the beta cells. In type 2, there is dysfunction of the beta cells, which is being there. Okay, so physiology of the human insulin, only 2% of the pancreas weight is endocrine, 98% is exocrine, that is digestive enzymes, and number of islets is 1 lakh, and number of cells per islet is 1 to 2000. So how much are the beta cells? That we already discussed, 65 to 70%, which is the main source of the insulin. Total insulin storage is about 200 units stored in the granules inside the beta cells. And how much amount of daily insulin release is being there? It is about 40 to 50 units per day. And 1 unit insulin, what it does, it lowers the glucose by 8 to 10 gram. So that's why this is important when you do the insulin calculation. So coming to the insulin, the miracle of the insulin, which we know. So how this has been developed. So there was Leonard Thompson, the first patient that was being treated with the insulin back in 1922. So before insulin, he was severely malnourished, you see, almost close to near death. And after insulin, look at this, a dramatic recovery. So insulin was being discovered by the Frederick Banting and Charles Best. And before insulin, the type 1 was a very fatal disease. Patient used to survive only for weeks to month. And after insulin, it became a treatable chronic disease. So why it is called as the miracle? Because the first drug to reverse a fatal metabolic disease. Now, coming to the difference between the human pork and beef insulin. So, human insulin, of course, alpha chain and beta chain. So, alpha chain, there is threonine. In the alpha chain, at the 8th amino acid, at the 10th, you have isoleucine, and at the beta chain, 30th amino acid, you have threonine. When talking about the pork, you have threonine, you have isoleucine and alanine, beef, alanine, valine, and alanine. So pork insulin differs by 1 amino acid, and beef insulin differs by 3 amino acid. So beef insulin is more antigenic, and pork insulin is very similar to the human insulin. So in the olden days, there was, animal insulin which was being used like porcine or bovine, and there was more kind of problems like allergic reactions, antibody formations. And now you have options of recombinant human insulin, E. coli, and insulin analogs has been there. So regulation of the insulin secretions either through direct stimulation. So glucose is the most important. Glucose enters the beta cells via the GLUT2 receptors channels, the ATP increases, then the K channels close, there is depolarization of the cells, influx of the calcium, and thereby leading to the release of the insulin. Then you have also hormonal regulation. So glucose dependent insulinotropic peptide, that is known as GIP, and then you have cholecystokinin CCK, that also stimulates the B cells. Then you also have the neuronal regulation. Parasympathetic stimulates the release of the insulin through the IP3 and DAG pathway, and then you have the sympathetic that inhibits the insulin release through the alpha 2 receptors. So rapid actions, you have metabolic actions, intermediary actions, you have increased GLUT synthesis of the enzymes for amino acid metabolisms. Long-term actions increase differentiation of the cells and play an important role in intrauterine and extrauterine growth. This we are talking about the insulin. So when we talk about the insulin actions, it has a metabolic, carbohydrate, lipid, protein, electrolyte. It has an anti-inflammatory action, even fibrinolytic, play a role in steroidogenesis, growth, and it also has the vascular action. So carbohydrate metabolism, the action of the insulin is to decrease glucose levels in the blood. There, how? By increasing the transport of glucose inside the cells, leading to peripheral utilization of the glucose, more glycogen synthesis, thereby decreasing the glucose levels, decreasing glycogenolysis, breakdown of glycogen to glucose, and decreasing neoglucogenesis, formation of the glucose from the other precursors. So this is the overall carbohydrate metabolism functions of the insulin. Lipid metabolism decreases lipolysis, more fat increases lipogenesis, glycerogenesis, decreases ketogenesis, and also plays a role in clearance of the very low density lipoprotein and chylomicrons from the blood through enzyme vascular endothelial lipoprotein lipase. It also has the protein and electrolyte metabolism along with anti-inflammatory, fibrinolysis, steroidogenesis, and vasodilatation. How? It acts by activation of the endothelial NO, and NO is a potent vasodilator, thereby leading to vasodilatations. So fate of the insulins, it is distributed only extracellularly, should be given parentally. Addition of zinc or protein decreases its absorption and prolongs the duration of the action. Half-life is 5 to 9 minutes and released from the pancreas in the monomeric form. So when we talk about the different types of insulin preparations, you have conventional insulin preparations extracted from the beef or the pork pancreas. But there were problems with the conventional preparations, contains 1% of the impurities like proinsulin, proteins, antigenic, thereby leading to more allergic reactions. And now this conventional preparations of the insulins has become more kind of the obsolete. Highly purified insulin, gel filtration, removes the impurities, and it contains 50 to 200 of proinsulin. So it is less antigenic than the conventional preparations. Then you have the human insulins, which is produced by the recombinant DNA technology, and it is identical and has minimum immunogenicity. So this is the most commonly used insulin preparations there. And then you have newer insulin analogs like, Rapid, Lispro, Aspart, Long, you have Glargine, Detemir. So what are the advantages of the new insulin analogs? It has better physiological control, and it also leads to less hypoglycemia. So these are the conventional insulin preparations: short, intermediate, and long. Regular, semi-lente, intermediate, lente, isophane, and long-acting ultra lente, protamine, zinc, and insulin. So onset of action is 0.5 to 1, peak within 2 to 4 hours, and duration of action for 6 to 8 hours. The intermediate is for 1 to 2, onset of action, peak within 8 to 10 hours, and duration of action is for 20 to 24 hours. When you talk about the long acting like ultra lente and protamine, onset within 4 to 6 hours, peak within 14 to 18, and duration of action is 24 to 36 hours. Highly purified insulins, you have single peak insulins that is purified by the gel filtration. So this contains 50 to 200 ppm pro insulins. What are the examples of highly purified? You have atrapid, purified pork regular insulin, monotard, which is being there, purified pork lente, mixtard, which is a combination of the 30% of the regular and 70% of the isophane NPH. So it is used for mixed insulin therapy. Monocomponent insulin, further purification of the monocomponent of the insulin possible through ion exchange chromatography, and it contains 20 ppm of the proinsulin. And what are the examples? Actrapid, monotard. So evaluation from the conventional to the purified to the humans to the analogs has been happened. So most commonly used today, you have humans, atrapid, monotard, insulinotard obtained by the recombinant DNA. What is the advantages of the human insulin? The advantages is it has a better solubility. It has faster subcutaneous absorption, so more predictable peak. It is less antigenic, decreases allergy and antibody formation. But there are some disadvantages, and when talking about the countries like India, where cost is the major factor when we talk about the use of drugs, so slightly shorter duration of the action. So standard therapy before the insulin analog still widely used in many settings because of the cost effectiveness. So what are the indications of human insulin? Insulin resistance. You need higher insulin doses. Allergy to the conventional preparations because it is less immunogenic. Injection site lipodystrophy. So switching insulin improves the fat changes during pregnancy. It is safe and can be preferred because it does not cross the placenta. And short-term use insulin in the surgery, acute illness, stress, hyperglycemia. So human insulin is preferred in pregnancy and allergy. Newer insulin analogs, you have the rapid and long. So in rapid, you have Lispro, Aspart, Glulysin. In long actin, you have Glargine and Detemir. Onset within 5 to 10, 10 to 15, and 5 to 15. Peak within 1 hour, and duration of action is generally between 3 to 6 hours. Long acting, onset within 1 to 2 and 2 to 3 hours, and duration of action is almost close to 24 hours. So when we talk about the rapid acting analogs, when it has to be given, it has to be given just before meals, and it mimics the physiological insulin spike. When we talk about the long acting analogs, drugs like Glargine and Detemir, so you use as a basal insulin once a daily. And what are the key advantages of this? The key advantages is it causes less hypoglycemia, better glycemic control, and mimics natural insulin pattern. So action profiles of the insulin, you understand the graph. Rapid acting is the Lispro. You have the Aspart and you have the Glulysin. It has very fast onset. There is a sharp peak. There is a shorter duration also. Regular insulin, slower bit of onset, peak at 2 to 4 hours, and duration is 6 to 8 hours. Then you have the NPH preparations, almost intermediate, peak between 6 to 10 hours. And then duration is for 12 to 16 hours. And long acting like Glargine, there is almost close to duration of 24 hours. You have Detemir, close to duration of 24 hours. So the clinical concept, if you have to understand this, a basal bolus regimen where basal is the Glargine, Detemir, and bolus is the Lispro and Aspart. So human insulin, of course, it is recombinant, less allergy as compared to the. So rapid analogs has to be given before meals, and long analogs are to be used for the basal control. So insulin analogs score over the conventional insulin, less nocturnal hypoglycemia, less weight gain, more physiological action profile, better postprandial glucose control, less pre-meal lag time, and improved predictability, tolerability, and flexibility. But there are adverse effects like hypoglycemia can be there. There can be allergy, obesity, insulin-induced edema, and even local reactions like lipodystrophy and lipoatrophy. Interactions of the insulin has been also there with non-selective beta blockers. Alcohol precipitates the hypoglycemia. Drugs like salicylates, lithium, theophylline can accentuate the hypoglycemia. Thiazides, furosemide, corticosteroids, OC pills, nifedipine increase the blood sugar levels. So uses of the insulins for type 1 diabetes can also be used in type 2 diabetic ketoacidosis and hyperosmolar non-ketotic hyperglycemic coma, which we'll be discussing. So indications in type 2, when you will consider in type 2, primary or secondary failure of the OHA. The patient is not being able to control the blood sugar levels on OHA. CKD, pregnancy, steroid therapy, fasting greater than 300 and HbA1c greater than 10, unintentional weight loss with or without ketosis, and type 2 diabetes mellitus with diabetic ketoacidosis where there is a severe beta cell dysfunction. So what are the recommended sites for subcutaneous insulin injections? Various marked sites. You can use the abdomen, thigh region. You can use also the part of the deltoid region also. So initial insulin doses in type 1 diabetes mellitus, you start with 0.5 units per kg per day with negative to moderate ketones, and if it is there is a large ketones, you switch to 0.7 units per kg per day. Now coming to the question in type 2, how you will initiate the insulin treatment in type 2. So there is either a weight based method, which is the most common, or there is a body weight divided by the 5. So the formula is you multiply 0.2 units per kg per day. So for example, if you consider the weight of the patient as maybe 70 kgs, so the total dose is you multiply 0.2 multiplied by 70, so that happens to 14 units per day. So you start with maybe 10 to 15 units of the basal insulin like glargine or maybe NPH at night. The second is body weight divided by the 5. So weight by the 5, again 70 by 5 is 14. So just as the same results like the above. The third is you calculate the dose on the basis of fasting blood sugar level. So what is the formula? Fasting blood sugar minus 50 by 10 or average fasting blood sugar divided by the 18. So for example, if the fasting blood sugar is 200, for example, so 200 minus 50 by 10, that is 150 by 10, that is 15 units. And again, the fourth is average fasting blood sugar divided by 18. So if you take maybe fasting as 180, 180 by 18 is 10 units. So which methods to use? Again, you have a lot of options, but in practice, you can start with weight base, that is 0.2 units per kg, which is the most preferred, or maybe alternative methods as to be you. Now, the next question is you have calculated the insulin dose. What type of insulin to start? So you generally start with the basal insulin, maybe insulin glargine, insulin detemir, or NPH insulin that has to be given once a daily at night. So titration of the dose is very much important. So starting dose is not the final dose which you give to the patient. So you have to adjust every 3 to 5 days. For example, maybe if the fasting blood sugar levels is greater than 130, you increase by 2 units. And again, if there is a hypoglycemia, you reduce the dose. So your target should be you keep the fasting in the range of 80 to 130 and HbA1c less than 7. Now, when to start insulin in type 2, we have already discussed HbA1c greater than 9 to 10. There is symptomatic hyperglycemia, the oral OHAs have failed, and if the patient is going for a surgery, maybe pregnancy or an acute illness, which has to be there. So now coming to the continuous IV insulin infusion. So continuous delivery of the insulin via the IV drip, and you use the regular insulin because only regular insulin can be given as IV. It has a rapid onset. It has a precise control. So when do we use IV insulin? Now again, coming to the next question. In diabetic ketoacidosis, in hyperosmolar state, in ICU patients, in critical illness and severe uncontrolled hyperglycemia. So again, you admit the patient, You start the insulin drip, regular insulin infusion, like maybe 50 units insulin in 50 ml of NS. So you start with maybe 0.1 units per kg per hour, and then you maintain the euglycemia for 24 hours. So maintain the blood glucose levels in the range of 140 to 180. If there is a hypoglycemia, rapid glucose drop, you have to avoid that. And you calculate the insulin requirement of the patient based on the 12 to 24 hours. So how much total amount of insulin that is you are using in the infusion over 24 hours is the patient's daily insulin requirement. So if the patient needed 40 units, for example, in 24 hours, that is the total daily dose of the patient. Now, once you stabilize the patient, you just give 80% of the total IV insulin dose. So IV insulin used 40 units per day, 80% of the 40 units is almost close to 32. So you start the subcutaneous insulin. Why 80%? Because again, IV insulin is more efficient and subcutaneous insulin has a slower absorption. So before you stop the IV insulin, give subcutaneous insulin 2 hours before stopping the drip. That will help in preventing the hyperglycemia. So if you have to understand, you start the IV insulin of the patient, you monitor glucose every hourly, you stabilize the patient, you calculate the 24-hour insulin requirement of the patient, you convert this to a subcutaneous insulin requirement 80%, and you stop the IV after the overlap. So use regular insulin as a IV. Dose is 0.1 units per kg per hour, maintaining a target glucose of 140 to 180, 80% of the IV requirement and overlap of the IV with the subcutaneous insulin. Okay, I hope I'm clear. Now coming to the pathogenesis of the diabetic ketoacidosis, so insulin deficiency, either absolute or relative, along with the counter hormonal axis because of the decrease in anabolism and increase in catabolism. So because of the decrease in anabolism, what happens? There is decreased peripheral utilization of the glucose, which is the prime function of the insulin. There is hyperglycemia, and because of this, there is heavy glucose urea. There is, because of the increased catabolism, breakdown, increased glycolysis, more formation of the glucose, gluconeogenesis, and increased glycogenolysis, breakdown of glycogen to form glucose, further contributing to the hyperglycemia. Because of this heavy glucose urea, there is loss of even the water and the electrolytes, further leading to dehydration in the patient, decreased fluid intake, leading to hyperosmolarity. So how ketoacidosis develop in diabetic ketoacidosis? There is increased lipolysis, increased free fatty acids to the liver, increased production of the acetyl and acetoacetyl, further leading to formation of what? Acetoacetate, beta hydroxybutyrate, and contributing to the acetone formation. So hyperketonemia, decreasing the alkali reserve and further contributing to the acidosis. So what should be your treatment plan for the diabetic ketoacidosis? Fluid therapy, correction of the potassium bicarbonate, antibiotics, treatments of the precipitating cause, and some general measures, and rapidly acting regular insulin. So fluid therapy, adequate tissue perfusion is very much necessary, and normal saline is the fluid of choice. So how much you will give? 1 liter in the first hour, next 1 liter in the next 2 hours, then 2 liters in the next 4, and 2 liters in the next 8. So that is close to 4 to 6 liters in almost 24 hours. Now, when blood sugar level reaches 300, fluid should be changed to 5% dextrose with concurrent insulin. So insulin in diabetic ketoacidosis, either a regular or a short acting IV, again a loading dose of 0.1 to 0.2 units per kg given as a IV bolus, and then 0.1 units per kg per hour by continuous infusion. Now the rate is doubled if there is no significant fall in the blood sugar levels. After 2 to 3 hours, you check the blood sugar levels. If it reaches 300, if the patients become fully conscious, encourage the patients to take more of oral food, and then you switch from IV to the subcutaneous insulin. Potassium replacement is a must. So in the presence of insulin infusion, serum potassium falls, hence 10 milliequivalents per liter potassium can be added with every third bottle of the normal saline. So serum potassium less than 3.3, 20 to 30 milliequivalents per hour has to be replaced. Bicarbonates, if the pH is greater than 7.1, there is no need of soda bicarb. But if there is a severe acidosis, you give 50 milliequivalents of the soda bicarb that is added to the IV fluids. Phosphate, again, potassium phosphate is not very much replacement is necessary if it is less than 1 milliequivalents per liter. But again, if it is there or so, then you replace 5 to 10 millimoles per hour of the phosphate replacement. The second complication is the hyperosmolar hyperglycemic state. So because of the decreased insulin, either a relative or absolute. So in an absolute, there is a diabetic ketoacidosis. So what happens to the release of the amino acids from the muscle and from the adipose tissue release of the free fatty acids, thereby leading to glycogenolysis, gluconeogenesis, and on the other hand, also contributing to the ketone body formation, further contributing to the acidemia. So if there is gluconeogenesis and glycogenolysis, there is more glucose, osmotic diuresis, and profound dehydration. So HSS is a life-threatening state. A severe hyperglycemia greater than 600, a high serum osmolality greater than 320, and a minimal or no ketosis because of the dehydration. And severe dehydration because there is massive fluid loss, almost close to 8 to 12 liters, and increased serum osmolality leading to cellular dehydration. So HSS, hyperosmolar non-ketotic coma, usually occurs in type 2. Generally, the treatment principle is same like diabetic ketoacidosis, but in case half NS is preferred in 2 liters in 2 hours, followed by the 1 liter in the next 2 hours. Even low dose heparin to prevent vascular thrombosis and intravascular coagulation. So dehydration with severe hyperglycemia without ketosis because insulin inhibits the hormone sensitive lipase. So treatment of HSS, you resuscitate the patient with the fluid 0.9% normal saline, start at the rate of 15 to 20 ml per kg per hour, and once the patient is stabilized, you switch to half NS almost 250 to 500 ml per hour. And when glucose is close to 300 mg per deciliter, you switch to dextrose D5 with 0.45% of the normal saline. Treatment of HSS, again, insulin therapy. So regular insulin IV 0.1 units per kg per bolus, and then after the bolus dose you continue 0.1 units per kg per hour infusion. So target, you have to decrease the glucose every hour 50 to 75 mg per deciliter, and once it reaches to less than 300, you reduce from 0.1 to 0.02 to 0.05 units per kg per hour. Potassium replacement, less than 3.0 potassium, hold insulin KCL 20 to 30. If it is between 3.3 to 5.2, 20 to 30 again. And if it is greater than 5.2, generally you keep the patient on monitoring and no potassium supplementation is being required as such. Insulin resistance. So normal insulin produces subnormal biological response. So what is the mechanism? So there is decrease in the insulin receptors, fewer receptor on the cells. There is decrease in the receptor affinity. Insulin binds it poorly. And what is the ultimate results? The glucose is not taken up. There is hyperglycemia. So what are the types? There can be acute, there can be stress, there can be infection, there can be steroids, and chronic because of the obesity or type 2 diabetes mellitus. Severe insulin resistance, requirement of greater than 200 units of the insulin per day in the absence of the stress. So it is common in type 2 diabetes mellitus and obesity. So body produces insulin, but tissues don't respond to it. So early leads to hyperinsulinemia and late leads to beta cell failure. So there are newer insulin delivery devices. You have pre-filled insulin syringes that is ready to use. You have pen devices, which is the most common. It is portable, easy dose, dialing is being there. You have jet injectors that is needle free, but it is expensive. Inhaled insulin powdered, again inhaled by the lungs. Insulin pumps, continuous insulin delivery used in type 1. You have external artificial pancreas, which is the future, and again a lot of research is being going on. And then you have liposomal insulin, which is again a lot of research is being going on through either oral, rectal, or intraperitoneal routes. So this is basically the insulin syringes and concentration. So insulin strengths 40 units per ml, that means a 40 U40, and 100 units per ml, that means a U100. So always match the syringe with the insulin strength. Do not mix it U40 with U100, and use insulin specific syringes. Do not use a tuberculin syringes accordingly. There is also a continuous subcutaneous insulin infusion, and it delivers the insulin by the catheters that are being placed under the skin. So what it helps? It helps in providing of the basal insulin. There is the continuous dose or delivery of the insulin which is being going on, and there is also a bolus dose which is being given after meals. So what is the advantage of this pumps, insulin pump? There is a precise control which is being given. It mimics the physiological insulin, and there is less chances of the hypoglycemia. Pen injectors, easy to carry, more expensive than the vials. Pros and cons: simplified insulin dosing, greater impact with highest, slightly less insulin use per day. Cons: more chances of diabetic ketoacidosis and severe hypoglycemia. Inhaled insulin, again, inhaled insulin that is delivered via the lungs. So, what are the advantages? There is no injections, there are faster onset than the subcutaneous insulin, and it has a better patient acceptance. But what are the advantages? Again, expensive. Variable absorption can be there, lung safety concerns, and definitely it is not for those patients who are chronic smokers and already a diagnosed case of a lung disease. So it can be used as an alternative to rapid acting insulin. Coming to the oral anti-diabetic drugs, so after the insulin, we have come now to the oral anti-diabetic drugs, and there are the various classifications which we'll be discussing. So basic classifications: you have sulfonylureas, meglitidides, biguanides, thiolidones, and then you have alpha glucosidase inhibitors along with incretin agonist and DPP4 inhibitors. So this is the classification of the oral anti-diabetic drugs. So drugs that enhance the insulin secretions, that even lead to K channel blockers, that are being divided into sulfonylureas and meglitinide. So what are the examples of the sulfonylureas which we'll be discussing? So there is tolbutamide, glyplizide, glyclazide, glimepiride, and meglitidine. You have repaglinide and nateglinide. Similarly, you have dipeptidyl peptidase inhibitors, that is DPP4 inhibitors. You have sitagliptin, you have vildagliptin, you have teneligliptin, linagliptin, and alogliptin. Drugs that overcome the resistance of the insulins. Metformin is a very good insulin sensitizer. And then you have thiazolidine that is pioglitazone. Then that retard the carbohydrate absorption. Alpha glucosidase inhibitors, you have acarbose, miglitol, and voglibose, and there are miscellaneous drugs like sodium glucose co-transport inhibitor, that is SGL2, dapagliflozin, canagliflozin, and then miscellaneous drugs of the dopamine D2 agonist like bromocriptine. So coming to the first, sulfonylureas, this is the enhanced insulin secretions, K channel blocker, sulfonylureas, and meglitinide. So sulfonylureas further divided into tolbutamide and chlorpropamide, that is they are the first generation, and the second generation drugs are glyplizide, glyclazide, glibenclamide, and glimepiride. So what is the mechanism of action of sulfonylureas? So what happens? So sulfonylureas are basically insulin secretagogues. they increase the insulin secretion from the pancreatic B cells. So drugs bind to the SUR1 on the ATP sensitive K channels on the beta cells, thereby leading to the K channel closure. So it blocks the ATP sensitive K channels. What happens because of that blockade? There is depolarization. Potassium cannot exit. The cells become depolarized. There is influx of the calcium and thereby releasing to the insulin release. How? Because calcium triggers the exocytosis of the insulin. So primary augment is the phase 2 insulin secretions, which we have already discussed. The insulin secretion has two phases. So phase 1 is the rapid, and then phase 2 is the sustained action, which is being there. So what are the additional effects of this sulfolene ureas which are being there? This is the, of course, what happens. So it also decreases the glucagon secretion. It has extra pancreatic effects, like it increase the insulin sensitivity, it increase the insulin receptors, and overall improve the glucose uptake. So what are the advantages? It is well absorbed orally, highly plasma protein bound, 90%, crosses the placenta, therefore contraindicated in pregnancy. Metabolization takes place in liver and excreted through the urine. So these are the daily drugs of sulfonine ureas, both group 1 and group 2, and these are the various doses, how much number of doses is being required per day, and based on the duration of action. So glimepiride almost close to 24 hours, glyplizide 12 to 18 duration of action, glyclazide 12 to 24, chlorpropamide is 36 to 48 hours of the duration of action also, which is being seen. Again, tolbutamide, special point, short acting, low potency, hypoglycemia chances are least likely. Chlorpropamide increases the chance of hypoglycemia. There can be disulfiram like reactions, can also lead to cholestatic jaundice. Glibenclamide, potent but slow acting. Glyclazide has an antiplatelet antioxidant action, may delay retinopathy. Glyplizide, fast acting, preferred in the elderly, and glimepiride has the extra pancreatic action, less hyperinsulinemia and less hypoglycemia. So with this sulfolane ureas, there is lesser risk of hypoglycemia. FDA has approved the combination therapy with the insulin. It leads to little or no weight gain, antiplatelet, antifibrinolytic activity, safe in the elderly and even mild renal failure, and has insulin sparing effect, increases plasma adiponectin, and stimulates GLUT4 expression. So why glibenclamide is more potent and longer acting than other sulfolane ureas, which we have discussed, may accumulate within the beta cells. Again, glibenclamide, 18 to 24 almost. So it has a slower absorption, slower distribution, inhibition of the hepatic insulinase, more suppression, and may stimulate the insulin sensitive, greater and longer binding with the SUR1 receptor. So it is comparatively more potent and has a longer acting than other sulfolane ureas. If we talk about the adverse effects of the sulfolane ureas, hypoglycemia, there can be GI disturbances like nausea, vomiting, weight gain, not safe in pregnancy, and chlorpropamide can lead to cholestatic jaundice. Dilutional hyponatremia can also be seen. Contraindications, pregnancy, yes. Severe infections, stress, trauma, renal failure, allergic, if the patient is allergic to sulfonane ureas, and type 1 diabetes mellitus. Drug interactions, drug that increase the action, salicylate, propranolol, varfonil, sulfonamide, cimetidine. And drugs that decrease the sulfonylurea action, you have corticosteroids, thiazides, frusamides, patient on ociphils, anti-TB drugs like rifampicin, phenobarbital, phenytoin. So these are the drug interactions with the sulfolane ureas. Clinical conditions, again, only postprandial hyperglycemia agents, glyplizide, renal impairment, you can glyplizide, gestational diabetes mellitus, glibenclamide, elderly patient, avoid glibenclamide and chlorpromamide, alcoholic, avoid chlorpromamide, diabetes, and if the patient is a patient of ischemic heart disease, you avoid glibenclamide. And if again diabetes, patient has a peripheral pitting edema, edema of the legs, avoid chlorpromamide to be there. So sulfonylureas, if combined with other anti-hyperglycemic agents, with metformin, best, with glitazones, best, with two or more drugs, with insulin, even good, and with meglitinides, not has to be combined, has a bad, and with other sulfonylureas, two, it is the worst combination. So choose wisely, live well, very importantly. Next is the meglitidine analogs, and it is almost has the same pathway as sulfonylureas. So it binds receptor on the B cells, lead to closure of the potassium channel, calcium influx occurs, and there is insulin release. But it acts on the different receptor subtypes of the SUR variants. So it has a faster onset, shorter duration of the action, taken just before the meals. And what are the advantages of the meglitidine analogs? Meglitinide analogs, sorry. It has less hypoglycemia and flexible dosing with the meals are being seen. So when we talk about the examples, you have repaglinide, well tolerated in the elderly and also in the renal impairment, indicated in type 2. So you start with 0.5 mg and you can increase to 16 mg per day. There are adverse effects like, mild headache, dyspepsia, arthralgia, or headache. The second is the nataglinide. Again, more rapid acting, shorter duration of the action. Adverse effects can be like dizziness, nausea, and given in a dose of 60 to 80 mg may be tedious. So mainly used in postprandial hyperglycemia without producing late phase hypoglycemia. Then you have biguanides. Again, what is the biguanides? You have metformin. Improves the lipid profile. So what is the metformin dose you will give? 0.5 to 2 mg gram per day. That has to be given in 2 to 3 divided doses, very importantly. So this is the biguanides. So what is the action or mechanism of action of the metformin? You give oral biguanides, you give metformin. Metformin enters the hepatocyte cells of the liver, enters the muscle cells, enters the GI tract. Therefore, it activates the AMPK. AMPK activation leads to decreased formation of the glucose, decreased liver glucose output, also increases the peripheral glucose uptake. How? Through the increased GLUT4 activity. So what happens because of this? Of course, there will be less intestinal glucose absorption and then there will be fall in the blood glucose levels. So this biguanides like metformin has to be taken orally, excreted unchanged in the urine, and it is well absorbed through the GI tract. It is not metabolized at all. So in obese type 2 diabetes, secondary sulfonylurea failure to reduce insulin requirements, these biguanides can be combined with sulfonylureas, glitazones, and even insulin. What are the adverse effects of biguanides? Nausea, vomiting, loss of weight, vitamin B12 deficiency, and there can be lactic acidosis. Rare, but again, skin rashes are also common. Contraindications: renal failure, creat greater than 5, creatinine clearance less than 40, patient who is an alcohol abuser, patient of a pregnancy, cardiac disease, or advanced liver disease, it is contraindicated. Coming to the next group, that is the thiazolidinones. So these are the insulin sensitizers. So it increases the glucose uptake, decreases the hepatic gluconeogenesis, and increases the insulin sensitivity. So how this, alpha glucosidase inhibitors basically, or glitazones, they act. So they are selective agonist of the PPAR. So it binds to the nuclear PPAR. It activates the insulin responsive genes that regulate the carbohydrate and the lipid metabolism, sensitize the peripheral tissues to the insulin, decreases blood glucose by how? Promote lipogenesis, increase glucose transport where? Into the muscle adipose tissue, and inhibit newer production of the glucose. So it binds to the PPAR. The delta, it increases the insulin sensitivity, it increases the glucose uptake, decreases the hepatic glucose production accordingly. So it has, of course, it has this Thiazolidines lead to a favorable redistribution of the fat from the visceral to the subcutaneous tissues. So hyperglycemia, hyperinsulinemia, and even elevated HbA1c levels are improved. Pioglitazones has no effect on the LDL levels, decreases the triglycerides and increases the HDL. Rosiglitazones has inconsistent effect on the lipid profile, increases the HDL and LDL. So both are completely absorbed from the GIT, highly plasma protein bound. Drug interactions are less with rosiglitazones, and metabolites of rosiglitazones are excreted in urine, and those of the pioglitazones are excreted in the blood. So what is the dose of the pioglitazone? 15 to 45 once daily. Rosiglitazone 4 to 8 mg once daily. So patients who benefit most are the type 2 diabetes mellitus with the substantial amount of the insulin resistance. It can be also used as a monotherapy or add-on therapy. You have to readjust the doses, and it also is used in PCOD. But what are the adverse effects? There can be mild anemia, sorry. There can be hepatotoxicity, although rare, weight gain because of the fluid retention and edema. And if the patient already has CHF, it can lead to worsening of the congestive heart failure. What are the contraindications? Not given in pregnant female, lactating mother, already having a CHF liver disease, and not to be used in children. Coming to the alpha glucosidase inhibitors, you have acarbose, miglitol, and voglibose. So how they act? So they inhibit the alpha glucosidase enzymes that is there on the intestinal brush borders. They decreases the breakdown of the carbs and thereby decreases the glucose absorption, thereby leading to decrease postprandial glucose spike. Acarbose inhibits alpha glucosidase as well as alpha amylase, reduces the postprandial hyperglycemia. In pre-diabetics, reduces the occurrence of type 2. And what is the dose of the acarbose? 50 to 100 mg TDS, given just before food or along with food. Adverse effects like, flatulence, diarrhea, abdominal pain can be there. Contraindications like inflammatory bowel disease and intestinal obstruction. But it do not cause hypoglycemia by themselves, but it may be caused if used with sulfonylureas. The second after acarbose is voglibose. So advantages of voglibose over acarbose and miglitol: 20 to 30 times more potent, superior tolerability, no dose adjustment is being required, and does not affect the digoxin bioavailability. What is the dose of the voglibose? Given in a dose of 0.2 to 5 mg OD. Now coming to the newer drugs for the type 2 diabetes mellitus, you have GLP-1 analogs like exenatide, liraglutide. You have DPP-4 inhibitors, sita, vilda, allogliptins, amylin analog, pramlintide, and you have SGL2 inhibitors and dual incretin agonist, and others like meglitinides, which we have already discussed. So SGL2 inhibitors, what is the example of SGL2? You have empagliflozin, you have dapagliflozin, and canagliflozin. So what is the mechanism of the acting of the SGL2 inhibitors? They throw the glucose out of the urine. So they decreases the glucose reabsorption by the kidney, and therefore, because as there is no reabsorption, there is increased glucose excretion in the urine. So what it does, it blocks the SGLT2 transporter in the kidney, in basically the proximal tubules. So thereby leading to decreased glucose reabsorption and more glucose in the urine. So what is the effects of SGL2 inhibitors? It decreases blood sugar levels, weight loss, decreases BP. So drugs, empagliflozin, what is the dose in which it is being used? 10 to 25 mg OD. Dapagliflozin, 5 to 10 mg OD. When to be used? Good for heart failure patients with type 2. CKD because it Possesses a renal protection and also be used in overweight patients, but avoid in patients who have a glomerular filtration rate of less than 30 and patients having recurrent UTIs. Next are the GLP-1 receptor agonists. So mimic incretin hormones. How they bind to the GLP-1 receptors, and these receptors are present in the pancreas, brain, and the GI tract. So what it does, because of binding of this agonist to these receptors, it increases the glucose-dependent insulin secretion in the pancreas, decreases glucagon secretion. So as there is increase insulin secretion, it increases the satiety in the CNS, thereby decreasing the blood glucose and the body weight. Through by decreasing the secretion of the glucagon, it increases again the satiety in the CNS, thereby decreasing the blood glucose and the body weight. So it increases the insulin, it decreases the glucagon, decreases the gastric emptying time, and decreases the appetite, thereby leading to weight loss. So examples, you have relaglutide, you have semaglutide, and you have dulaglutide, which is being there. So what is the dose? Liraglutide 0.6 to 1.2 to 1.8 mg given as a subcutaneous. Semaglutide 0.25 to 1 mg subcutaneous and oral 7 to 14 mg OD. When you can use obese patients with having diabetes, patient having a cardiovascular disease, atherosclerotic, and even for patients who need weight loss. Exenatide, synthetic GLP-1 analog that is resistant to DPP-4 inhibitors, suppresses the release of the glucagon, suppresses even the appetite, slows the gastric emptying time, increases the postprandial insulin release, and injected subcutaneously twice daily, 1 hour before the meals, and acts for 6 to 10 hours. Most common side effect is nausea. Coming to the DPP-4 inhibitors, what are the most common examples? Sitagliptin, linagliptins, and vildagliptins. How they act? They inhibit the DPP-4 enzyme. So they prevent the breakdown of the GLP-1. So thereby leading to increased insulin and decreased glucagon. So oral glucose incretins in the small intestine, they increases the insulin, they decreases the glucagon, decreases the plasma glucose in the liver. So glucagon promotes the glycogen breakdown to release the glucose, we know. So what is the function of the DPP-4 inhibitors? They amplifies the glucose dependent insulin release and they also inhibit the glucagon release. So what are the advantages? It can be used in elderly patients, patients who have a low hypoglycemia risk in mild diabetes, and dose sitagliptin 100 mg OD and linagliptin 5 mg OD. Sitagliptins, oral active DPP-4 inhibitors, 100 mg oral OD is the daily dose, no action on the weight and lipids, and mainly used in postprandial hyperglycemia. But it has no action on weight and lipids, and it is also on the costlier side. Pramlintide, it is a synthetic amylin analog, improves overall glycemic control given as a subcutaneous before the meals, can be used even in type 1 in patients are well tolerated, but there are side effects of the pramlintide like GI disturbances, less hypoglycemia when it is being used alone. Dual incretin agonist, you have tirzepatide. So it acts on the GLP-1 and GIP inhibitors. So thereby leading to increase in insulin, decrease glucagon, decrease appetite and massive weight loss. So as it acts on the GLP-1 and GIP receptor agonist. So GIP receptor agonist and GLP-1 receptors which are present in the pancreas. So it acts on the pancreas GLP-1 receptor. What it does? It increases the secretion of the insulin, decreases glucagon secretion, decreases gastric emptying satiety. Through GIP receptor activation, increases the insulin activation, more enhanced fat metabolism, decreased satiety, decreased food intake, weight loss. It enhances the fat metabolism. So, how it is given? Given as a 2.5 mg weekly dose, and it can be, the dose can be increased to 5 to 15 mg weekly. When to be used? Severe obesity, poor glycemic control, and those who need strong HbA1c reduction. Semaglutide again acts like endogenous GLP-1, same similar action, increases glucose-dependent insulin secretion, decreases glucagon release, decreases gastric emptying time, and increases satiety, thereby leading to weight loss. So in type 2, start with 0.25 once a weekly, increase 0.5 weekly dose, maximum of 1 to 2 mg weekly. And if the patient is obese, you give a 0.25 mg weekly dose. So gradual increase can be there from 0.5 to maybe 1 to 1.7 to up to 2.4 mg weekly dose. So oral dose indications of this semaglutide, what are the oral dose? This we have discussed, the subcutaneous. So you start with 3 mg OD, then maybe 7 mg, then up to 14 mg. In a patient of type 2 diabetes with poor control, or if the patient is obese, maybe BMI greater than 30 or greater than 27, patients who need weight loss, even atherosclerotic cardiovascular disease patients, this can be used. So principles of the treatment of the diabetes mellitus, and this, this again, we talk about semaglutide, the famous drug Ozempic, which has been there in the market, again, which has been used for weight loss. And all kinds of celebrities are also adopting and taking this method. So principles of treatment for type 2 diabetes, either a mild, moderate, severe. For severe diabetes, start on insulin if there is weight loss and ketoacidosis. For mild to moderate diabetes mellitus, use metformin if obese, and sulfonylureas if the patient is not obese. So fasting blood sugar between 150 to 200 is a mild with a HbA1c less than 8. 200 to 250 is a moderate with a HbA1c 8 to 9. And more than 250 is a severe HbA1c 9 to 10. So classify whether the patient is obese, non-obese, check the liver function is properly functioning or not, check the kidney function. So patient who is a new onset of diabetes, whether it is a whether it is a type 1 or a type 2. Now, if a patient has been diagnosed as a type 1, through diet and insulin, you control this. Type 2, diet and exercise, controlled, uncontrolled. Uncontrolled may be a mild, uncomplicated, severe with complications. So mild patients with obese, start with biguanides, controlled, very good. Uncontrolled biguanides, sulfonylureas or meglitidine analogs, thiazolinones or biguanides or sulfonylureas, or TZD plus biguanides or sulfonylureas. Controlled, very good. If the patient has hyperglycemia, obese patient, postprandial hyperglycemia, start with sulfonylureas or meglitidine. Sulfonylureas, if it is uncontrolled, follow the same approach. Controlled, very good. Meglitinide, I'm so sorry, meglitinide, if it is uncontrolled, again follow the same step of the biguanides with sulfonylureas with meglitinide. If the patient is uncontrolled, having underweight, complications, pregnancy, infection, surgery, start with the insulin, control through this, and switch over if the patient is uncontrolled of this to insulin along with biguanides to make a final control of the patient. So always remember this flow chart, a very good flow chart. Now this is also a very good flow chart which has been given by the American Diabetes Association, how you will start the first line therapy or treatment of the patient of the diabetes mellitus. So first line therapy is metformin, lifestyle changes. If HbA1c above target, proceed as below. So established a patient of either a heart disease or a kidney disease. Heart disease predominates, start with GLP-1 inhibitors, which has proven CVD benefits, or SGLT2 inhibitors with CVT benefits if the GFR is adequate. If still HbA1c above the target, further intensification is required or patient is now unable to tolerate these GLP-1 inhibitors or SGLT2 inhibitors. Now again, choose the agents that has a safe cardiovascular profile. So what you will choose? Either consider adding the other class GLP-1 inhibitors
or SGLT2 with proven CVD benefits, DP4, basal insulin, TZDs, or sulfonylureas. Heart failure or CKD if predominates, so start with SGLT2 inhibitors. Or if SGLT2 is not being tolerated or contraindicated, add GLP-1 with proven CVD benefits. Again, if HbA1c above the target, avoid TZD, choose from this class. So consider adding the other class that has proven CVD benefits, DPP4 inhibitors, basal insulins, or sulfonylureas. Compelling needs to minimize hypoglycemia, DPP4 inhibitors. If HbA1c above target, you can choose SGLT2 or TZD. GLP-1, if HbA1c above the target, you can start with SGLT2 or TZD. Compelling need to minimize hypoglycemia, SGLT2. If HbA1c above target, switch or add GLP-1 or DPP4 or TZD. TZD, if you have started, if HbA1c again above target, SGLT2 or DPP4 or GLP-1. Again, if HbA1c above target, continue with the addition of other agents as outlined above. Again, if it is above target, consider the addition of the sulfonylureas or basal insulin. Compelling need to minimize weight gain, GLP-1 inhibitors with good efficacy for weight loss, or SGLT2 inhibitors. Above target HbA1c, SGLT2 or GLP-1 with good efficacy for weight loss. Again, HbA1c above target, triple therapy, SGLT2 or GLP not tolerated or contraindicated, and preferably DPP4. If the patient doesn't tolerate the DPP4 or contraindicated, you can use sulfonylureas or TZD or basal insulin. And if cost is a major issue, sulfonylureas, TZDs, HbA1c again target, switch to TZD and switch it. Just reverse it. If you have started with sulfonylureas, switch to TZD, started with TZD, switch to sulfonylureas. Again, if above target, insulin therapy. Or consider adding DPP4 or SGLT2 inhibitors with lowest acquisition cost. So always remember this flowchart. This is a very good flowchart for the overall control. If diabetes not controlled, look out for the failure, occult infection, added infections, TB, UTI, drug history, compliance, food history, and compliance has to be ruled out. If there is a cardiac problem, avoid glitazones. If in failure, maybe CHF, avoid metformin. If renal problem, avoid metformin. Liver problem, avoid glitazones and metformin, and in general, patients with complications, short acting sulfonylureas or insulin can be started. Beware of the other drug interactions which we have discussed: diuretics, corticosteroids, other hormones, and ACE inhibitors. Some complications of the diabetic retinopathy leading to microvascular damage to the retina, further leading to the vision loss. So how you will control it? A proper annual checkup with the ophthalmologist, and if it is progressing, maybe every 6 months, anti-vascular endothelial growth factor injections and laser photocoagulation with strict glycemic control has to be done. Diabetic neuropathy, glycemic control, foot care is very much important. If there is a secondary or underlying infection, added antibiotics, maybe with debridement and surgery or amputation if there is a large involvement of the deeper layers of the dermis or muscular layers. Drugs like pregabalin, gabapentin, and duloxetine can also be given. Nephropathy, ACE inhibitors, ARBs, control the BP in less than 130 to 180, strict control of the glycemic levels, and avoid the nephrotoxic drugs. Coming to the case presentation, just a brief case presentation. A patient, a female, young female, 14 years, just having a weight of 36 kg. She presented with clinical features of polyuria, polydipsia, polyphagia, along with weight loss. So it is acute onset history, 10 days. There is progressive symptoms. There is no prior history of the diabetes. There is no history of infection or trauma. So no comorbidities in the patient. There is no prior drug history. There is no prior even family history of the diabetes. A random blood sugar level taken of the patient, it was 4118. Urine ketones were negative. HbA1c greater than 10. Serum electrolytes AVG was normal. So patient diagnosed as a case of type 1 diabetes, started on insulin therapy, 0.5 units per kg per day. Calculation, as the patient's weight was 36 multiplied by 0.5, that roughly amounts to 18 units per day. So how it was given? So 50% was given as the basal dose, as 9 units of the glargine or NPH at the bedtime, and then 50% as the bolus dose, which was being divided into 333 units given before breakfast, before lunch, and before dinner. Split mixed regimen, 2/3 in the morning and 1/3 in the evening, and patient education, how to use insulin, awareness of the hypoglycemia with strict diet and carbohydrate counting and regular glucose monitoring has to be done. So 18 units per day, basal bolus therapy, which is ideal for the better control and the flexible lifestyle. 50% basal dose, 50% bolus dose, 9 U pre-meals, 333. 18 units per day as 5 shot per day. So you divide it into 50% basal dose, 9 units divided by the 5. Pre-breakfast per plus 4 units at bedtime. So 50% of the bolus dose, again 9 units that is being there, that has been subdivided into 333 before breakfast, before lunch, and before dinner. 18 units, 2 shots per day, so 2/3 pre-breakfast and 1/3 pre-dinner. So pre-breakfast 8 units plus 4 units because it is 12, and pre-dinner 3 units of NPH with 3 units of the regular. That has to be divided. So either 18 units as 5 shots per day, 2 shots per day, and 4 shots per day. Coming to the clinical case 2, patient Mr. Y, 62 years, a BMI of 30 kg per meter square. He's an obese male. Chief complaints, he has an altered sensorium. Severe dehydration is being there. There is polyuria and there is also weakness. The patient is a known diabetic since 10 years. There is poor drug compliance. There is recent infection which has been there, and there is reduced oral intake. So RBS was greater than 600. Osmolality greater than 320 and minimal ketosis. So diagnosis of HHS, hyperosmolar hyperglycemic state, was being made. Blood glucose was 720, serum sodium high, potassium was variable, ABG shows no signs of acidosis, and urine ketones was negative. So patient was started with 0.9% normal saline, 1 to 1.5 liters in the first hour, and then switching to 250 to 500 ml per hour. Insulin therapy, IV 0.1 units per kg bolus, then 0.1 units per kg per hour of the infusion. The target, you have to decrease the glucose by 50 to 75 mg per deciliter per hour. So potassium levels, again, less than 3.3, you hold it. If between 3.3 to 5.2, you give 20 to 30, and greater than 5.2, you just monitor the patients. When glucose becomes less than 300, you add dextrose D5 plus NS and reduce the insulin to 0.02 to 0.05 units per kg per hour. Long-term management of the patients has to be started with oral anti-diabetics, metformin, 500 to 200 mg per day, SGLT2 inhibitors, dapagliflozin, 5 to 10 mg per OD, and DP4 inhibitors like sitagliptin, 100 mg per OD. Even advanced therapy like GLP-1 agonist, like semaglutide, the patient can be started with 0.25 mg weekly up to 1 milligram. Along with all this, weight control, diet control, avoid dehydration, preventing the complications of the diabetes, and follow up with regular kidney, lipid, and HbA1c every 3 months has to be done. Thank you, and hereby I end my presentation.
Doctor? Uh, Doctor, can we start the Q&A session?
Yes, for sure.
Yeah. Thank you, doctors. Can you please drop in your questions? I will, yes, Dr. Dinesh, we will post the certificate link. Uh, 1 second, give me a moment. Yeah, I have dropped the certificate link on the chat box. Please do fill the form to get your certificates right into your inbox. Sometimes, if not in inbox, please do check in your spam box. The certificates will be landed on your spam box sometimes. It is not something our mistake. We are trying hard to get into your inbox, but due to unavoidable circumstances, it is ending up in spam folders. Please do get it there. So we do have one question actually, sir. How could we use insulin injection in case of insulin resistance? As in such a case, our cell are resistant to insulin at all, whether it is natural insulin or synthetic. I mean, what is the role of this insulin injection in insulin resistance?
So basically, what happens, and although there is insulin resistance, which is there in type 2 diabetes along with the obesity, but still insulin works. But you need higher doses along with the correct strategy. So if there is a insulin resistance, tissues do respond poorly to the insulin, but you require more insulin at the end of the day to achieve the same effect. For example, when you will suspect a insulin resistance, if the requirement is greater than 1 units per kg per day, or if there is a severe insulin resistance, there is greater than 2 units per kg per day of the requirements, or even 200 units per day. So you start with a higher basal dose, maybe 0.2 to 0.3 units per kg per day, instead of the 0.1 to 0.2 which we discussed. So a more higher dose is required. So again, aggressive titration, maybe increase the dose every 3 to 4 days if your fasting blood sugar level is still high, and if post meal the levels are still high accordingly.
Thank you, doctor. Thank you for answering that question. We have one more question. Can safe can it safe to give insulin therapy along with sulfonylurea?
Yes, it is definitely safe because sulfonylureas increases the endogenous insulin secretion. So early in the insulin initiation in type 2 diabetes mellitus, when the patient is already partially controlled on sulfonylureas, you can add basal insulins and you can continue the sulfonylureas. But this again combination is limited. Why? Because there is high risk of hypoglycemia, because both have an additive effect, both increase the insulin, and insulin along with the sulfonylureas can also lead to weight gain. So that's why you have to again frequently monitor and do accordingly.
Dr. Gaurav is asking, can you explain again 24-hour IV insulin regime?
Think I have already covered if the PPT is being shared. That I have already discussed how do you calculate the insulin dose, and based on the 4 shot regimen, 5 shot, or morning, evening, 2/3 and 1/3 regimen, that is being very well I have covered in the PPT. You can again go back and you can see there are very beautiful points which I have highlighted. Again, you will have a brief overview of it, how to do it.
Yeah, Dr. Gaurav, you can once the session is closed or completed, you can add on to our live section in our YouTube channel. You will find this video already live, so you can just repeat the class and you can hear it again and again. Not to worry. Uh, so Dr. Savia is asking how to start BD dose.
Dose of what?
That is the okay. Dr. Savia, please be clear with your questions next time.
BD dose of oral, BD dose of what you're talking. So
Yeah. Vivek is asking in CKD or CLF dose adjustment for rapid insulin.
So for rapid acting insulin, basically like Respro, Aspart, or Glulysin, it is used for Postprandial control, normally there is no fixed dose reduction formula, but it requires individual titrations. So why there is dose adjustment which is being needed? Because kidney helps in clearing about 30 to 40% of the insulin. So in CKD, there is decreased clearance, insulin lasts longer. So if it is a mild CKD, maybe even having a GFR greater than 60, so there is no major change. If it is a mild, moderate CKD, in a GFR between 30 to 60, then you reduce the dose by about 25%. And if there is an end stage renal disease, you start with low, almost less than maybe 50% of the usual dose, and but accordingly, frequent monitoring is being required.
Thank you, Doctor. Virendra, you should already got direct PDF to your email ID. So please do check in your inbox or spam box. If you have submitted the form properly, there is no delays. In minutes, you will get the certificates to your email ID. Dr. Gautam is asking again, how much useful is bariatric surgery in type 2 DM combined with high BMI obesity?
Is definitely useful, but again there are high recurrence rates. Almost maybe recurrence rate of 60 to 70% are being seen, but again it has a good role, bariatric surgery.
Okay. No, Dr. Sabia came with a full question. How to start do 2 doses in a day, along with which combination and in what condition for how many days?
I've already discussed, Dr. Sabia. There is a flow chart, if you remember, which I've already talked about, which dose to start and how to start accordingly. If you monitor accordingly your HbA1c, you start maybe with metformin or any of the drugs, and accordingly, based on if the patient is a CKD or a cardiovascular profile. So based on the flow chart, if you just go back maybe 5-7 slides, which I have discussed, so there is a very beautiful flow chart which you can again, maybe keep a track of it, maybe print it down, and you can have, for future references. So everything is being covered in that.
Great. Dr. Narayan is asking, SGLT2 inhibitors are not useful in CKD due to ADP-JD IMO. I think, is it a question? I don't know. Please, Dr. Narayan, please uh, send us your full question so that doctor will get a context to explain. Dr. Gautam Rai is asking, is it safe to give only oral medications for type 2 DM whose blood sugar random is 400 mg per DL if patient doesn't want to take insulin?
It doesn't depends on if the patient doesn't want or not. It all depends upon whether his glycemic control is being there or not. So if random is 400, maybe a newly onset diabetes mellitus, what are his HbA1c levels, whether there is a complication, and if he has a newer onset of diabetes mellitus. So you have to do a complete thorough workup profile of the patient. You can definitely start with the oral anti-diabetic drugs, which is if the patient is a type 2 diabetic case. But again, if it is not being controlled, patient has become, still on the higher side, HbA1c is on the higher, fasting is on the higher, not being controlled, which we talked about the mild, moderate, and severe category. So you have to switch to insulin. There is no other chance.
Thank you, Doctor. Dr. Lavish Tyagi is asking, sir, why does weight loss occur with SGLT2 inhibitor? Um, okay.
Yes.
Ex- uh, Explain dose adjustment in chronic liver failure for rapid insulin.
No. What was the before question to this? Why?
Why does
Just
weight loss occur with SGLT2 inhibitor?
because there is loss of glucose in the urine, what they because and they act on the SG2L2 SGLT2 receptors, so they also lead or cause negative caloric balance. They also causes mild diuresis, and mostly it is kind of a fat loss. There is loss of visceral fat, some kind of amount of the water loss is being also there.
Thank you, doctor. Many of them are asking for the PPT. Doctors, we have live session recorded on the YouTube channel. You can just go there and watch uh, it how many times ever you want. So it is in your YouTube channel. Please subscribe to our channel. Let me also do one thing. I'll just drop in our social media channel links for you guys to not that way. It would be great help for you guys to just add there. I have dropped the links. I will also drop again the certificate link for you guys if anyone has missed it. Just give me a moment. Yeah, I have again dropped the certificate link. Doctor, one last question. Divya is asking how to treat patient with diabetes type 1.5.
How to treat?
Patient with diabetes type 1.5.
So basically, what happens, there is, of course, autoimmune destruction of the pancreatic beta cells, which is being there, and classical symptoms like, polydipsia, polyuria, polyphagia can be there. So accordingly, you have to do a thorough workup with fasting glucose, HbA1c levels, and do look out or rule out autoantibodies. So insulin is definitely again an important component which is being there, which has to be used, and if it has to be used along with the oral anti-diabetic, that has to be again prescribed. So it is basically a autoimmune form. You have to rule out the autoimmune type 1, combining with type 1 with the autoimmunity. So ruling out the autoimmune form is very much important, and of course insulin is the key. Often it is mostly misdiagnosed as a type 2, but again it can be managed with diet, exercise, and of course insulin injections are have a role.
Great. Thank you, doctor. I think we can call it a day. Thanks for all joining the session, and Dr. Ayush, thank you so much. Like always, I know it feels like I just repeat it again and again, but no, no, I don't repeat it. I really mean it when I say your sessions will always be great. It's always interactive. It's right on point, always depth. So thank you for that. Thank you for joining today. Thank you for shedding the light on this topic. Diabetes is something, like you said, it has been a pandemic, and it is also becoming uh, uh, another identity here in India. So it is too difficult to manage. Thank you for having such important topic today, and thanks for all the listeners who have patiently sat down till 8:30 p.m. And that shows the commitment, and this kind of engagement what thrives Mediversal Academy to conduct more such webinars. Just a small announcement, to be, if it is helpful, we have beautiful sessions lined up for the month. Please head on to our social media channels just to know what are the sessions are lined up. Thank you so much. Thank you all. Thank you, doctor. Thank you for joining. I'll be here 2 more minutes. If you want, if anyone wants, I can again drop the certificate link if anyone need it, or you can call it a day. And thank you, doctor. Thank you, Dr. Aish. Thank you so much.
Thank you, Vijay, and thank you all the participants. Have a great evening ahead. Thank you. Take care. Bye bye.
Good night. Good night, doctor.
Good night.
Doctor, sir, I'll be here. If anyone wants to come on record, and if anyone wants to give us a feedback, just raise your hand. We will let you give us the feedback, or use the form to feedback. Okay, great. Thank you all. Good night.